Welcome to tonight's program. I'm really excited. This is probably one of my new favorite subjects to talk about. For 40 years, I would say the catchphrase in all of our practices is watch. We're going to watch. We're going to watch. And I think this program tonight is really about making you think a lot more. It's about, yes, a particularly game-changing product. But I want to be clear here. I think it's part of an overall shift and a continued shift to minimally invasive dentistry. I want to share that tonight we're going to be talking about a game changer in prevention that I would say for 100 years, this is what we've been seeking in dentistry. It's about a mindset change in both your initial exams, and I'm going to even say in our recall exams. I think this will change the mindset in my own dental practice, and I would say thousands of other dental practices in the United States. I'm going to share with you a technology that couples with advanced diagnostics that I truly believe we should all be incorporating into our practices. And then it really leads into a modern day era of dentistry. And I'll start with, what do you think a game changer is in dentistry? And I would say implants were an absolute game changer in dentistry. I would say veneers were a game changer in dentistry. Aligners were game changers in dentistry. Sleep appliances have become game changers in dentistry. But for prevention, I'm going to say not a lot of game changers. And this is a game changer tonight. So we'll start with the age-old question. And the age-old question that's going to be out about our story tonight is to watch or not to watch. And on all the Facebook groups that I'm on, and they show x-rays and treatment planning, the diversity of opinions it's just omnipresent on every Facebook post. And so do I drill? Do I watch? Am I waiting too long? And we have to take this guessing game out of our everyday practices. So tonight I'm going to focus just on one patient, and his name is Danny. And I'm going to tell you there are thousands of Dannys in all of our practices throughout the United States, throughout everywhere in the world. There are Dannys everywhere. And I believe it's time really to change our assessment in evaluating risk. And it will be tonight, I'm not talking about periodontal risk. Tonight, I'm talking caries risk, but both absolutely apply. So Danny, in our practice, is 26 years old. He was first seen in 2017, which I'm going to show you. He has a history of ADHD. We treat his parents and siblings. He brushes twice a day, and he says he rarely flosses, which we all mean he never flosses. And these are his original x-rays. And I'm just going to ask you, yeah, there'll be contrast issues, and you can all be yelling at me or saying, should they be more contrast or whatever? But when you look at these x-rays, what are you watching and what surfaces are you watching? This is his right side, and this is his left side. Yes, I see the contrast is off on one of the images, but I'm just going to share with you, this is life every day. These are the images we took. And you definitely see things, but do you see everything? So the doctor at the time elected to watch everything. That's just what the doctor decided to do. And the doctor basically used 3 diagnostic elements: an explorer, 2D x-rays, and their eyes. And I will say to you, that's what 80% of dentists, maybe 90% of dentists are doing in the United States today. They're using those 3 elements to diagnose decay. And the subjectivity of those 3 elements has got to go away in the it's got to go away in dentistry. So let's just start with some facts. So when you imagine flipping a coin, you imagine if you yell, say, heads or tails, it's 50-50. So I'm going to relate that to our diagnostics in modern day dentistry today in all of our practices. The Explorer, the accuracy of a brand new Explorer, forget a 2-month-old Explorer, is 52%. So every day your hygienist hands you an Explorer after the hygienist has gone pick through all the occlusal fissures, not around the margins of crowns or composites. The accuracy is 52% in finding decay. So it's 50-50. If I then ask you radiographic sensitivity, the radiographic sensitivity, as you look at this one study, shows the radiographic sensitivity of dentinal decay. Actual dentinal decay is 58% interproximally. So you have x-rays that are 58-ish%. You have explorers that are 52%, and you have your eyes. And why is that all we are relying upon? Imagine going to a cardiologist and you have a heart scan done, and he goes, well, it's 50-50 if you've got disease. That's how archaic we are still practicing in dentistry. And yes, we have plenty of solutions for this, and it's time we make a shift. And it's not just that one study that you can find when you Google it. Here's a study about dental radiography has really not improved with sensors at evaluating interproximal decay. This was a study done in 2012 on non-cavitated lesions. And it actually found film was superior to sensors in sensitivity. Sensitivity is on the left. Specificity, which is no condition, no pathology, is far more accurate. When you're looking at enamel dentin caries, film is still more considered accurate than sensors. Now, you can disagree, but this was one of literally dozens and dozens of studies that are showing the accuracy of 2D imaging is really no more than flipping a coin, just like an Explorer. Yet, that's what we do every day. And all of you have seen this. You go in and you take out a restoration, an occlusal restoration, an old amalgam. And as you're taking it out, you're approaching an interproximal area, you see decay. You look at the X-ray and you don't see it. Why? Because the accuracy is around 55 to 60%. So basically, just by going the traditional route, this doctor who used an Explorer, X-ray diagnostics, and her eyes was guessing on evaluating E1, early enamel breakdown, E2, deeper enamel breakdown, and D1, early dentin lesions. And you can see we didn't have these technologies. Yes, we did. We've been using CaryView in our practice since 2014. Spectra is a fluorescence technology that can actually read the depth of porphyrins in fissures, and even when you're taking out decay. Diagnodent's been around 30 years now, 30 years. And those of you who use Diagnodent, and I know many of you do, Diagnodent is far more accurate than an Explorer. And if a Diagnodent reads 50 and your Explorer doesn't stick, you're absolutely going to drill, because the number of false positives is far less with Diagnodent. So the technologies have existed, and tonight I'm going to show you a progression to even, I think, more state-of-the-art technologies that allow us to be better diagnosticians. So now the patient comes back to the practice. They did not come back in 4 years. And Danny sees the next dentist in the group. And what did the dentist do in the group? The dentist used an Explorer and X-rays, their eyes, and the dentist again decided, I'm going to watch. So I'm just being humble here. The original dentist watched everything, and the next dentist watched everything, and now we're in year 4. So I want to talk about tonight how we can really up our game. I'll get you to the additional X-rays. Don't worry, you'll all be seeing them. And I want to talk about regarding really upping our game diagnostically in all of our practices. And I'm going to tell you caries detection with AI is one feature of 2D AI. And whether it's Pearl, who's our sponsor tonight, or Overjet, or other companies, AI has certain features that you just have to understand. The human eye, when they're reading x-rays, can see a maximum of 50 shades of gray, maximum. No matter what you do, if 50 dentists are looking, they can only see up to 50 shades of gray. When AI is introduced into the equation, AI can read 300, 500, and to a maximum of 800 shades of gray. Now, you can get false positives. There's no company right now that can say we don't have false positives or false negatives. Nobody's going to stipulate that. But after using Pearl for 4 years, and how many things Pearl has diagnosed in our practice that we have missed, visually missing, yours truly included, the opportunity is to understand AI technology, AI-driven software can see far more than the human eye. To that point, this study showed the accuracy going from 58% on x-rays to the mid-80s on x-rays for D1 early dental lesions. So you're talking about a 30% increase in accuracy. It didn't say it was 100%. I have seen no study that says it's 100%. But we all have to understand that we're limited in our own visualization with our own eyes of reading x-rays. So here's Danny now in 2021, and I've opened up Second Opinion. That's the software that immediately opens up. We have DEXIS software in our office, DEXIS sensors, and JAZ sensors. So we have 2 types of sensors, one software, and it integrates right, Pearl integrates right into that. The way Pearl operates, for those who don't have it, there are multiple icons that you normally would have them all on. And in this case, I have calculus appearing with the green, incipient caries in light pink, and deeper pink is progressive caries. So what happens is, as your x-rays pop up on the screen, if you see a colored dot, it tells you Pearl has found pathology. It's up to you to confirm it or to say that does not exist. But the role of Pearl in 2D AI is to give you a second opinion just to make sure we don't miss anything. So let's take a look at number 1. That's the x-ray with a green dot, a light pink dot for incipient decay and progressive decay. This is now the year 4 years after Danny was in originally. So this is traditional imaging. And you can start to look and go, okay, I see that, I see that, I see that. Well, when you start implementing, and this is just one icon on, this is showing progressive caries that are into the dentin. So I'll go back. And you may say the mesial of the upper bicuspid doesn't look like it's indentin, but it actually, according to Pearl, is. It's still up to you. And I would transilluminate this tooth just to verify it, but that's going to be talked about later. When we're looking at incipient lesions, here are incipient lesions. And I want to show you, even Pearl can question itself. On the left are the incipient lesions. On the right are D1 lesions. Now I'm going to highlight the upper second molar. Pearl identifies it as incipient and also a D1 lesion. So it's up to you now to evaluate, in this case, based on the angulation of the x-ray, slight angulation, it came up differently. So I'm going to tell you there is no 100% in anything. This allows you to visualize, but now you see 4 potential, at least 3 incipient lesions on a patient who we've been watching, who now has multiple D1 lesions. This is why it's a game changer in evaluating 2D AI. Now I've turned on all the features, so I can look at probing depths, and I shouldn't even say probing depths. I can look at the depth from the CEJ to the crest, so I can look at bone levels. I can look in green for subgingival calculus that the studies show we miss 50% of the time, and it's there. And this is just all enhanced 2D AI. For the few $100s this costs in our practice, the amount of new dentistry that we see and the amount of communication that we can express to our patients makes this just a game changer in our practice over the last 4 years. And this is just one other feature, and it's tooth parts. And it allows you to explain to a patient in color the different parts of the tooth along with the caries. So I'm going to go to Danny's right side, same year, 2021. Again, maybe the contrast isn't great. In Pearl, you can add contrast to this. Just like Dexis, you can change the contrast. But this is as soon as you turn on the icon looking for caries, you can see now much more clearly that Danny has 2 incipient lesions and potentially 2 progressive lesions. And you go back and it's just not as readable. It's still up to every doctor to work with their hygienist, and that's why I would use transillumination to verify they go hand in hand. And then when you take your mouse over the lesion, you can see how far it's progressed beyond the enamel in a progressive lesion. So this is 24%. So even if you're watching things over time, if the angles are very close to each other when you're taking the x-rays, you'll actually be able to see if the lesion's getting deeper in that if you're just watching it. Another lesion with 38% dentin penetration and a little bit of overlap. And because of the overlap, it may not be as accurate. The more accurate the x-ray, the more accurate the diagnosis from Pearl. So are you really going to watch number 4 mesial and number 31 mesial? And for the record, the doctor was watching everything. So the doctor using traditional 2D imaging, their eyes and an Explorer continued to watch everything. So I want you to understand some of the options today that we have to treat these early lesions. These are non-cavitated lesions. And in our practice, we have used Icon, which is a resin infiltration. It infiltrates and it leaves a translucent infiltration. The studies have shown it works very, very well. It's a very cumbersome technology and it's expensive per tooth application. Silver diamine fluoride is a wonderful remineralization process and antibacterial treatment, but we all know that it can leave teeth black. Fluoride varnish basically is a superficial remineralization of demineralized areas. It's not going to penetrate beyond 40 microns into a tooth surface. So the game changer is Curadont Repair Fluoride Plus. It is an absolute game changer. I'm going to explain it to you tonight, how to apply it and how this works. So why is this a game changer? So I'm going to walk you through Curadont Repair. Our video, that's why we were late. We could not get it to play. It will be in the stored version of this presentation in Catapult Education. So what I want you to understand is that it comes in a fluid form, and I'll walk you through how this works. As you place this fluid form onto a tooth surface, it is called a self-assembling peptide. So it actually self-assembles as it's being placed into a demineralized acidic environment. This is for non-cavitated lesions. So it will actually penetrate to the depth of the entire demineralized area and self-assemble as a peptide, in the sense that now you see a scaffold and it will attract calcium and phosphate, which I'll show you on the next slide. So you have this self-assembling peptide that is now Subsurface, it's penetrated through the non-cavitated area, and calcium and phosphates that are natural in saliva are going to permeate through into this self-assembling peptide. And with that, it will create caries inactivation, and it also can remineralize into new hydroxyapatite. So the video, which I'm sad to say I can't show you, actually shows you how the self-assembling peptide absorbs calcium and phosphate. And as it's doing this, it creates new hydroxyapatite crystals, thusly increasing the mineral density and ultimately, ideally, remineralizing the tooth back to its whole self. That's a game changer. We've never had anything this easy, this inexpensive to apply to a tooth. With one single application, which is all you routinely need, is to penetrate to the depths of the demineralization, then to create the new hydroxyapatite. Now you're going, Lou, does it work? This is typical of what we're asked. Does it work? Research of 10 years plus and maybe longer of the research, and even a systematic review in 2023 from the ADA. Oh yeah, this works. And I just want to highlight some of the studies. And there are numerous. So you can go to Vivardis's homepage, find the studies. You can Google Curodont Repair and then Curodont Repair Fluoride Plus. Same product, one's in Europe without the fluoride. But when you look at the studies and you look at day 0, 3 months, and 6 months, where it says caries inactivation, the comparison is gray to what we would call a varnish application to Curodont Repair plus a fluoride varnish, which I will get to. So what they found at 3 months, you had 48% inactivation. At 6 months, you had 80%. So understand this is an ongoing effect. The scaffold continues month by month to absorb the calcium and phosphate to inactivate the caries. And in this study, 80% of the caries were inactivated. When you look at the next study using laser fluorescence, the caries regression, as you can see again, with a varnish application was far more than just a fluoride application, and it increased from 3 months to 6 months. So there is this ongoing remineralization, caries inactivation process going on. So in this study, as we look at it, 14.3% basically were just stabilized. In this study, 70% of the teeth remineralized. So they had regrown hydroxyapatite. And I don't want to, I want to make sure you see the bottom one. 14% continued to demineralize. Now we're going to talk about, can you apply this again and again? And the answer is yes. But please understand, not every patient has the same risk factors. Not every patient has the same oral hygiene. Not every patient has the same diet. So those risk factors will affect this, just like risk factors affect every composite every doctor places. The higher the risk factors, the more chances of recurrent decay, the more chances of demineralization. So this isn't a one and done for life. This is often a one and done to remineralize the tooth. And if it's a stable home care, low risk environment, you can have success with just one application based on the studies. Let me kind of walk you through, and I'll get to the technique in a little bit. The technique is a very simple technique where you're activating a powder into a liquid form, and the technique takes to activate it 10 seconds. And I'll give you highlights. After 10 seconds, the sponge in the tip is now activated with solution. So this is the process, and then I'll skip to the technique. Great.
Enamel, made of hydroxyapatite, is the hardest tissue in the human body, which covers the crown and provides the tooth with its strength. The appearance of a tooth can range in color from a light yellow to a bluish white, which is due to the way that hydroxyapatite and dentine scatter light. Enamel is composed of 96% hydroxyapatite, with remaining 4% being proteins left over from its original formation. Once formed, the delicate balance of demineralization and mineralization keeps the enamel healthy. Modern lifestyles may disrupt this balance, shifting to extensive demineralization. Once this happens, caries lesions form, which can vary in their severity and depth. Formulated after decades of research, Vivartis technology exploits natural amino acids chains designed ability to self-assemble in acidic environment, found within caries lesion. The peptides are initially a fluid, existing as separate rod-like structures. Within acidic conditions, these rods instantaneously form a large matrix, which acts as a scaffold guiding tooth remineralization. The surface of the matrix attracts calcium and phosphate from saliva like a magnet. On application, our formula easily diffuses into the lesion, the scaffold instantly forms, and attracts calcium and phosphate from saliva. Hydroxyapatite crystals regrow, naturally remineralizing early-stage carious lesions, preventing other types of invasive and damaging interventions like sealing and drilling.
I think it's because I don't want to be in presenter mode. I now want to show you the technique. Here we go.
Repair Fluoride Plus, it's important to have all the necessary materials ready. This includes the Curadont Repair Fluoride Plus applicator, etch, isolation materials, and any additional tools needed for the procedure. By organizing our tray beforehand, we ensure a smooth and efficient application process. With Curadont Repair Fluoride Plus, we can treat any early enamel lesions that have not yet cavitated, including interproximal and around orthodontic brackets. Let's watch how easily these cases can be completed in as little as 5 minutes of chair time. Clean the lesion to remove the salivary pellicule. You will then rinse and dry and apply your etchant directly to the lesion. If applying to the interproximal area, use unwaxed floss to distribute the etch. Again, rinse and dry very thoroughly. Now it's time to isolate the treatment area utilizing basic methods such as cotton rolls, dry aids, and a suction. Activate the sponge applicator by removing the black clip and pushing the sponge into the reservoir. Let the sponge soak in the liquid for at least 10 seconds before removing the tip. It's important to use the provided sponge applicator in conjunction with the liquid for efficacy. Remove the saturated sponge and squeeze directly on or near the lesion surface. It's important to saturate the lesion before moving on to a new site. Each applicator can treat up to 3 lesions depending on the size and depth. Once saturated, you can remove the applicator from the lesion. Now, wait 5 minutes using the suction as needed to keep the area dry and the patient comfortable. Discharge the patient with instructions to not eat, drink, or rinse for 30 minutes.
Glad we could share those with you. So to review, all you have to do is basically remove the clip, push the tab down, wait 10 seconds as a minimum, and then bring the sponge over. It is my understanding that not only dentists, but hygienists and assistants can be applying this. Just some helpful tips. This can obviously be placed on early non-cavitated class 1 lesions. Interproximal lesions, the way we use this in our practice, and we did this even a few years ago, was we would take a packing instrument and pack it interproximally after it was cleansed and etched. And if you have orthodontic bracket patients and you're seeing white spot lesions, this is another key indication, or for general white spots, which I'll touch on in just a few minutes. So let me just go through white spots. What you're looking for are chalky lesions, chalky, not shiny, chalky lesions with a rough surface. Usually those are in plaque retentive areas. these are the areas that we can treat white spot lesions. We may not resolve the white spots fully, but we can be remineralizing beneath the surface, and that's the goal. With white spot lesions, and it's up to the clinician, you may want to reapply it in 3 months or 6 months. And I think a white spot application approach with multiple applications may be the way to go. And then ultimately you can replace the white spot on the surface. But again, you're not drilling, you're removing the white spot in the most efficient way without drilling and removing enamel. You can also apply this with Curodont Repair Fluoride Plus when patients are coming in who are high risk. They have high acid diets. And if you're not seeing on x-rays that you're taking or on 2D AI, you're not seeing either remineralization or the caries may be progressing, then reapply it. And you should be telling the patients that based on their risk factor, you may be reapplying it in 6 months or a year. In our practice, and the way we have done it is we place varnish immediately on it. And I'm going to explain why the varnish now. Curodont makes their own varnish, which I'll touch on in a few seconds. We can use Reminpro from Voco, MI Paste from GC America as varnishes. And basically they are applied, I would say the recommendations are in the area just twice a week. Now, if you look at these studies, you will see that they say Curodont Repair plus fluoride varnish. And what I will tell you, the studies really have not shown a big difference between using the Curodont Protect varnish and an MI Paste or a Reminpro type varnish. But when you look at in 360 days, in this study, they had 100% inactivation using a varnish with Curodont Repair. I mean, that's a game changer for all of our patients. No drilling. In this study, they found 93% regression and arrest. So some remineralization, but 93 overall percent. 7% or roughly 6.9% progress. So again, you are going to have to assess your patients on recall visits. But in my practice, I would turn to a Maya, a Celia, and say, as we're seeing our patients and we're taking x-rays, we should be comparing x-rays year after year. And now we can follow so much closer with 2D AI. And I'll close on that in just a few minutes. I think it's important to realize that Bavardis's product, where they call it Curodont Protect, is also a self-assembling peptide. So it would be my assumption, with stannous fluoride included, that this would be an incredible aid in the varnish application. So our offices, after applying the Curodont, should be selling the patient either a varnish of choice that's not Curodont Protect or Curodont Protect. But I don't believe just placing the repair material is enough unless the patient is truly low risk. For example, in Danny's case, he's high risk. You're going to want him applying varnish at least twice a week because he's high risk. If someone's low risk with one lesion, then I'm not so sure the varnish is required and you can follow that. But in high-risk patients, I would absolutely be coupling the treatment with a varnish. And the indications for higher risk would be orthodontic patients, children that do not have fully mineralized teeth, patients with high history of caries, patients during aligner treatments are at higher risk, and also patients with sensitivity, because you will get decreased sensitivity applying any of the varnishes I have shown you. Codes. If you want to take a picture, take a picture. These are the codes. And obviously, I like to double code with a fluoride varnish over a 2991. And then if you're going to be doing an at-home treatment, with fluoride treatment or a varnish, that's your code of a 1208. So ultimately, there are multiple codes that you will be using as you're doing your treatments. The do's and the don'ts. You must clean the surface, and I would absolutely say no fluoride in the pumice. Use a fluoride-free pumice. There are many on the market. You're going to etch for 15 seconds. And after you're etching, as the video showed, interproximally, you're going to take unwaxed floss and guide the floss through the etch a few times. Try not to create any bleeding, and then you will rinse away. You'll then, after that, you're going to apply the sponge. It's that simple. Clean, etch, apply. I don't know how much easier a system could possibly be. And you're going to tell the patient no eating or drinking for 60 minutes. Don't say 30, say 60, because they're going to cheat. They all cheat. If you say 30, they're going to be rinsing in 10 minutes or eating. So say 60 minutes. If you're working alone, so in our practice, if an assistant has the time to do this after a hygiene visit and she's working alone to place the material, she would actually activate the capsule first, let it sit in the unit soaking, and then she would basically cleanse the tooth, etch the tooth, do her isolation, and then just pull the sponge out. Much easier if you're working alone to follow that sequence. When you're doing same-day treatment, if a patient is diagnosed with, let's say, an early lesion, what I would absolutely do is at the end of, let's just say, let me go back. On same-day treatment, after the hygienist, if the hygienist is routinely just booked upon booking, in our practice, there's often no time, then the assistant would take her into the next room and do this solo, just as I just explained it, then dispense the remineralizing products. If the patient's coming back for additional work, just add 10 minutes. So if my buddy Tony is doing a class 2 or a crown, and he knows that there are 2 early lesions, at the end of the visit, the dental assistant can do this, or he can do it with the dental assistant. And then you're going to apply the varnish immediately thereafter and dispense remineralizing products. Again, nothing to drink for 60 minutes, nothing to eat for 60 minutes. So how do you know if it's worked? Well, you should see no radiographic progression. That's the first way. You can use transillumination to see if there's been any progression. You can actually look to see if there's been remineralization. And you can see remineralization on a radiograph or transillumination. Or on a white spot, does the white spot start to decrease in size? So with radiographs, these are just examples. The red is before, and you can see the blue is afterwards. You can see the lesions have decreased in size and have remineralized, or I would say partially remineralized. With AI, this was given by an Anna Blake, and this is using Overjet. On the left is the before, and on the right, 6 months later, Overjet did not detect any incipient lesions. On one of my patients already early on, this was an E2 lesion using CaryView. 12 months later, I actually would tell you there was some remineralization, but absolutely no growth in size. And again, why drill when you can remineralize and deactivate the caries? So in Danny's case, you got to understand the risks. Everybody, we all have to understand each patient is different. Danny has higher risks. So as we look at risks and start putting, in a sense, the pieces together or connecting the lines, how do we handle recall visits? And how would you really follow up his remineralization status? And I think it's patient by patient. So I'm just going to close with about 7 more slides And I think these are the game-changing slides of how we put this all together. In our practice, we practice giving hygienists 1 hour for patients, and these are adult patients. I don't treat kids, I can't stand them. So routinely, this is for adult patients. And this is for adult prophies or adult 4910s, perio maintenance. This is not active therapy. Routinely, the hygienist is instrumenting no more than 20 to 25 minutes of her 1 hour appointment. A key part of the appointment is the hygienist's oral hygiene instructions and evaluating the patient's risk nature. And it might be a dietary risk, going over their diet each and every visit. Are you drinking acidic drinks? What are you drinking with? Snacking. We all know what contributes to caries. Again, as you're trying to understand risk. Then when you look at the clinical screenings portion, this is where our hygienists spend the most amount of their time. So now imagine in our practice, the hygienist is taking her yearly x-rays, and she can use AI to follow these lesions that are being treated much more closely after curodont repair. So if the incipient lesion is not growing or it's gone, you know it's either regressed fully with remineralization or it's inactivated. And this is how we can use 2D AI to the next level. We can use products like GC America's Tri-Plaque Gel. When you see white spot lesions or plaquish type lesions around the gum level, what Tri-Plaque Gel will do is it will actually show you old plaque over 48 hours, or new plaque that they just missed that morning, or light blue plaque, which is highly acidogenic plaque, which means caries inducing. If it's caries inducing, you may then want to apply curodont to that area. And now you're going to educate the patient on better, obviously, brushing and flossing. There's a new product that will hit the market called CaviSense. You place it interproximally between two teeth, and if the tip turns yellow, it shows that the pH is now below 5.5 and it's demineralizing the tooth structure. So there's actually demineralization. I would do this before doing the prophy to see if we have active demineralization. If you do, this is another indication for curodont repair. And this to me is going to be the next big home run with Pearl. It's the Diagnostic Vision Full HD. It allows you to not only take an amazing HD image where you can see, you can actually see hypocalcifications. It allows you to transilluminate and fluoresce the teeth. So now you're looking at 3 different ways of assessing risk factor. And how can we now use this to guide our minimally invasive dentistry? And you can use combinations of all of these diagnostics, especially for your high-risk patients. And I'm going to just tell you the next big thing is going to stem out of GC America's saliva, their saliva buffering or their saliva check kit, where you can evaluate pH and buffering capacity. Now with saliva swabs, you can use oral genome, and oral genome can evaluate 6 to 8 diagnostic tests, both for, glucose, both for PG, saliva buffering capacity, pH, and more, MMPs. Or you can do an oral risk test on a high-risk patient, or on literally as a new patient, a one-time only test that assesses patients in a polygenic way of whether they're high risk, intermediate, or low risk for genetic biomarkers for periodontal disease and caries. So when you look at all these different diagnostics, it's going to enhance all of your information. It's going to enhance all your communication. And honestly, we have to change, because this is what I would demand in my practice. And I don't see why my practice would be any different for all of yours. Caries and periodontal disease are the 2 most omnipresent diseases in all of our practices. This allows us to be far more customized in our diagnostics, in our treatments, and then also in our preventative approaches, like with a curodont repair. The number one premise is you don't want to just tell a patient something. Premise number two is you want to show them. And the last premise is you got to involve them. If you involve and show your patients your treatment plan acceptance using these diagnostics, whether it's preventative or surgical in nature, will be so enhanced by these customized approaches that we should all be doing in our initial exams and far more also in our recall exams. And as I close, I just want to say that with today's diagnostics that are available to all of us, and they're not killers financially at all to our practices, we can customize our approaches to caries treatment and caries management. And what I truly believe, this will allow us in our own practices to enter the next era of dentistry. Far more minimally invasive, far more the way it should be practiced, and far less subjective. I'm going to thank you all tonight. I am absolutely going to take some questions. So I'm going to stop sharing the screen. So, Mark, you asked the approximate cost of Curodont. I will tell you the approximate cost, I believe, is around $35 when you open the package. I will tell you the application that we have found in our practice, you can apply this to two interproximal areas like right and left side, so you can treat up to 4 lesions interproximally, or maybe 3 occlusal lesions. So the cost per application routinely is around $17. I would be charging about $100 in my practice. That's what I would charge. And if you want to charge, it's $100 for one application and $75 per for multiple applications because it's open. That's how I would approach it with the coating. I would add the coat for a varnish, and then I would sell, absolutely in a high-risk patient, additional varnish for them to go home with. Do you charge per coat per tooth? And the answer is I absolutely do. So if it's a 19 mesial, then it's 19 mesial. If it's 19 distal and 19 mesial, just like a composite or an amalgam, if you're still using it, I charge per tooth per surface. What about gingival bleeding issues? So if you are applying this in an area that's been cleansed, I would absolutely tell you we've got to stop the bleeding. So both Vista Apex and Ultradent make great, what I would call products that stop bleeding. And usually, routinely, they're of a ferric sulfate type solution, but I would absolutely stop the bleeding before placing any material. No doubt about it. I mean, you can't place this in blood, but Ultradent's solution and Vista Apex's solution stop bleeding within 10 to 15 seconds. So that's how I would approach it. What do you do for root caries? Is Curodont effective? Well, for root caries, again, this is for non-cavitated. So you cannot use this if it's cavitated and it's geriatrics, then I'm going to silver diamine fluoride and routinely using an RMGI to cover over that area. And again, if it's cavitated, it's a silver diamine fluoride. I'm going to tell you, SDI makes, to me, the most cosmetic and easy to use silver diamine fluoride, and it's called Riva Aqua. There's no ammonia in it. It doesn't burn tissue. But for true root caries, that's what I would be using. Next question. Is this something that you find insurance will cover? I routinely will tell you, we all hate insurance companies. They're the deniers. We all know they deny. So what I will tell you is, as if we're treatment planning these, my team will go out and find out if these codes are covered. If they're not, we will obviously come back and tell the patient they're not covered. But please understand how we're going to introduce this to the patient. This is a well-proven technology that can prevent your teeth from decaying further. And without such, there's a higher likelihood that they will continue to decay. and I'm going to have to drill. Nobody likes to be drilled on. And we all know composites and everything else fails over time. I don't care how great you are, everything over time fails. The chance that we can regrow back enamel and remineralize it, that's for you to explain to the patient and for them to see the value if their insurance doesn't cover it. Okay. New patients are blown away when we tell them, they share with their friends. I couldn't agree more. I'm going to tell you this. In our office, we digitally scan every new patient. I mean, the scanner's there. We use Pearl and we identify all and we show them what AI is all about. This is the way you get rid of PPOs. I'm sorry, PPOs are the death of us all. The more value you show a patient, the more they share your information with their friends. And this is how you build a practice. So I think Curadon is absolutely a part of that. Do I know when they're going to be available in Canada? You're going to be able to ask Casey that when he comes on, or I think, Casey will be coming on and you can ask Casey that. Is Curadon work also with decay that is slightly passed into the DEJ? I love that nobody wants to give me their names. I love names. So here's what's very, very interesting. I want everybody to hear this. There are numerous studies that say if you put Curadon in a non-cavitated early D1 lesion, it will halt caries and remineralize over time. It may take additional treatments. When you go after this course and look up in the literature what Curadon can do with D1 lesions, the answer is yes. So if you have a patient with an early D1 lesion like Danny that I showed you, you can say to Danny, we can try this, and it may take two rounds or 2 applications, and in a year, let's evaluate this. I understand that we're trying this, but we're trying to be minimally invasive to avoid the drill. More often than not, patients will go, if you're going to tell me there is a good chance this can stop the decay and remineralize, I will tell you the majority of our patients will want that. I know they're going to ask, does insurance cover it? But now we have something that really offers something totally different than the drill. I can't tell you enough how more minimally invasive we can go with this. Okay. After treatment, does the chalky enamel regain typical enamel luster? So this is a very good question, Barbara. And my feeling is that, Barbara, if you apply this once and it's still chalky, I would bring the patient back 3 months later, no more than that, and apply it again. If you wanted to bring them back, there is nothing yet in the literature about this yet that I have read. So, Barbara, it's again up to you because it can get a little pricey because it is $35 each time. But the way I look at it, if I was to do even 3 or 4 treatments 2 months apart, I would be expecting the chalkiness to start to remineralize, and then I treat it like a traditional white spot lesion if I just want to remove it. Icon has a great white spot removal, but it doesn't remineralize beneath. So my goal is let's remineralize first, and then if we have to remove the white spot, the cosmetic part, we can do that much more minimally invasive. I would expect it to become more shiny, Barbara. Yes. Okay, now I'm getting a ton of questions, so hang on, everybody. Does it remove the white spot for a lesion like Icon? And the answer is not necessarily. Icon can infiltrate both a shiny lesion and an opaquish kind of chalky lesion. I don't like it for chalky lesions. I really don't, but I have used them for both. I find I have much more success with Icon with 3 or 4 rounds of treatment, 3 or 4 rounds, same day, using their hydrochloric acid, and then following the same thing up to 3 or 4 times with more shiny restorations. With chalky, I've had less success because I know there's active demineralization beneath it. So yes, you may get some penetration. I just can't tell you the depth of the penetration with Icon. Okay. Do you use around old composite margins? You know, Mark, I don't know that yet. I haven't started that. This is relatively new to all of us. So I don't know if we can actually, in a sense, remineralize stained or breaking down margins. If it's a broken down cavitated margin, I would say no, but I am not absolutely going to say that. When we have our next maybe webinar on this in a year, I'm sure that hundreds of us will have more input into this. Doesn't silver diamine fluoride have the same effect? It does. But silver diamine fluoride is antibacterial. This is not antibacterial. Silver diamine fluoride does remineralize a tooth. It does. But I again want to say you the negative aspects of it are the blackness. So it will not remineralize a tooth to the same level of rebuilding hydroxyapatite. It doesn't do that. What it does, it penetrates through the enamel into dentin, and it truly remineralizes the dentinal aspect. I do not believe the studies, and I can be wrong, that silver diamine fluoride remineralizes enamel. I have not seen that. I know it can in dentin. Again, I'm just saying in dentin. What do you find if the patient doesn't change their oral hygiene routine, if they still don't floss? So I'm going to be careful with this one. If a patient isn't going to change their hygiene, then the areas are going to continue to demineralize. So if they said, doctor, I'm lazy, I'm absolutely not going to do anything on home care except brush my teeth, then okay, look, if you want to pay $400, $500, $600 a year to me to keep your, early lesions from not growing, I'm going to have to be replacing this every 6 months to a year because demineralization is going to occur. You still can offer that to a patient. And if they say, I don't want to do it, then they don't want to do it. And you just document. I think this is our way of getting patients to follow much better oral hygiene. They're investing in their mouth. And the other one I'll tell you that you all have to look up is slate. It's called SLATE. We evaluated at Catapult. Lisa, I know I'm running late, but the questions are almost done. Slate is a power flosser. And I will tell you, many of us who evaluated this product, including myself, feel it's a game changer for flossing. So again, there are ways to increase better home care. Last question. Is there any way to remove the black stain few months after application of SDF? Yes. I mean, if it's a cavitated lesion, if it's cavitated, you're going to go in. And the whole idea is then you're going to either bond a restoration or place a resin-modified glass ionomer. In Riva Aqua, SDI's product, you get much less staining because it's a two-part system that uses potassium iodide, and you get significantly less staining, significantly less. So if you're an SDF person, I would absolutely look at Riva Star Aqua.